Good evening, everyone, and I thank Dr. Deepak Puri and the whole cardiology team for giving me this opportunity. It has been a wonderful session today evening, and I have learned a lot, especially in relation to the complex PCIs in Bella supported. I shall be talking a little bit about the mechanical complications of acute myocardial infarction, how we manage them, the surgical aspects. So, as we see, we all have been perceiving that the quality of cardiological care, cardiac care has been improving in all cities, metro cities, tier 2 cities and all other cities. So, even small towns are now having cath labs. So they are able to diagnose the cardiological events better, the myocardial infarctions or the acute coronary syndromes, and they are able to manage better with thrombolysis and PCIs and patients with chronic stable angina also. So we expect that the patients having severe myocardial infarction leading into mechanical complications, the tendency should reduce. We will see the statistics shortly. The important mechanical complications that may occur in the acute phase include ventricular septal rupture, the acute mitral regurgitation, and a free wall rupture. Pseudoaneurysm formation is a more of a long-term thing, so we shall not really be touching on that. So briefly, the papillary muscle rupture, it can lead to acute severe mitral defect that arises because of necrosis of the interventricular septum. You see the blackish portion of the IVS, and that has necrosed following the acute MI, and the patient will develop a large left to right shunt and become severely symptomatic. So this is a pseudoaneurysm that may form after maybe 10 to 15 days or maybe 1 or 2 months following a myocardial infarction in a particular territory, usually the lateral wall or the inferior wall of the ventricles. And this can lead to its own complications for the thrombus formation and emboli and heart failure. Another fatal complication could be a free wall rupture, coronary artery involved in a myocardial infarction. That would lead to necrosis of the free wall of the ventricles, either the left ventricle or the right ventricle inferior wall or anterior wall, and that can lead to catastrophic complication of free wall rupture, so severe pericardial tamponade. So we'll quickly look at each of these and see how they are managed. This is an important, let's say, diagram that indicates that 4 different eras of management of cardiological events: the perfusion era, the stenting era, and primary PCI era, and now the shock, the shock trials and modern era. So if you see here, the white line, the incidence of the complications has been more or less the same, roughly about 1 to 2% of the myocardial infarction. If you see the mortality bars, in the pre-reperfusion era, the mortality was high, almost to the tune of 70 to 80% of these important mechanical complications. It has definitely come down with the evolution of therapies. However, there has not been a very drastic change even with the more modern treatments. So that is definitely a cause of, let's say, introspection and maybe further efforts to improving the mortality figures related to these complications. So coming to the pathophysiology and management of post-MI VSR, we all know the important coronary arteries of the heart, the LED and the left system and the right system. You have the LED and the LCS, and you have a right coronary artery which divides into the PD and the PLV. So depending on the area of the infarction, you can have the ventricular septal rupture. If you have the LED or the anterior arteries of the heart involved in MI, you will expect a apical or anterior septal VSR. If you have the artery involved, you will expect an inferior VSR. So what essentially happens is that most of the patients wherein you see the VSR usually have critical single vessel disease. They don't have chronic long-standing triple vessel disease, because that will lead to formation of good collaterals and you won't expect a VSR. So poor collateral formation and a sudden complete obstruction in this artery involved with the occlusion, that predisposes to the formation of the VSR. So you can have simple or complex VSRs, wherein if you have an anterior VSR, usually there is a direct communication between the LV and the RV, and the track is not serpiginous, it is straight. So surgically also management becomes a bit easier. If you have a more complex VSR, as in the inferior VSRs, which happens because of the involvement of the right coronary artery and its branches, you can see that the track of the VSD is serpiginous, so you may miss closing the VSD completely during surgery. So that is important to understand the pathophysiology of these two types, because it has a bearing on the management, surgical management. So these are some of the diagnostic features. And pathophysiology, you obviously will get a massive left to right shunting because of VSD, depending on the size of the necrosis of the septum. And then the shunt fraction you can calculate based on the cardiac catheterization. You will see all these various signs. You will have a holosystolic murmur, a palpable thrill, and patient will be in pulmonary edema, and you will have S3 gallop or auscultation. So depending on the size of the VSR and the relative balances of the SVR, means systemic vascular resistance and the pulmonary vascular resistance, you will have patients having either relatively hemodynamic stability or patients who are in chronic cardiogenic shock. So you can have various levels of hemodynamic compromise related to VSR. Some investigations that may confirm your diagnosis, obviously echocardiography is the important one, and coronary angiography will give you the artery which is causing the obstruction, involved in obstruction leading to the VSR. So cardiac catheterization, if it is done, that will confirm the VSD. You will get step-up values and all. So important to stabilize these patients. You have to give them vasodilators to reduce the afterload, that will reduce the left to right shunt. You will have to start inotropic support if the MAP is low and the renal perfusion is compromised. And the importance of this condition is that it has a very high mortality within the first 24 hours and in the first week. In the first 24 hours you may have 25% mortality, in the first week you have 50% mortality. So it is very important for the setup to be geared up to diagnose and treat this critical condition. This is a operative, schematic diagram showing a large VSR, and one or two points on the management by surgical technique. You have to instill rapid CPV, you go to moderate hypothermia, and you have to ensure that the myocardial protection is excellent. Then usually the surgeon would approach the VSR using a trans-infarct approach. You have to thoroughly trim the margins of the left ventricular VSR border, and this is important because you may just, if you just visualize the defect part and if you ignore the adjacent unhealthy area of the septum, and if you close the VSD, it may recur again after 2-3 days because of continuing necrotic process. So another important point is that you have to close the defect with the patch without tension, and then subsequently you have to close the ventricular properly. As you see here, it's a very big patch. It is intentionally kept big so that it is sutured into the area of a relatively normal and healthy and viable septum, and then sometimes the patch is brought out onto the ventricular wall also to strengthen the closure of the ventricular septum. Some schematic diagrams. This is a single patch technique on the LV side. The patch has been placed on the LV side, and the ventricular closure has been done. Another approach wherein this is the inclusion technique, wherein you put the patch in such a way that the infarcted area is completely closed on both the sides, the LV side also and the RV side also. So even if there is some underlying necrotic process happening in the subsequent period also, that can be taken care of. And this is another approach wherein if you have an apical infarct with the underlying VSD, you can amputate the apex of the left ventricle and close appropriately, so that the patch closes the VSD and the amputated part of the left ventricle and the right ventricle is closed off with the direct suturing. So these were some of the surgical techniques. We're not going into too much of detail of that. You can have some early post-operative complications related to these closures. Low cardiac output syndrome, patients can go into low renal output situation. You can have patch dehiscence and recurrence of the shunt. That can be a very dangerous situation, and patients can have arrhythmias. So some of the results, if you see, several databases have indicated that overall 30-day mortality is around 40%, which is the highest of all cardiac surgeries. And if you delay the repair, maybe after about 7 days from the occurrence of the event, if you repair within 7 days, there may be mortality up to the tune of 55%. If you do a delayed repair by stabilizing the patient, if the patient allows it, patient's condition allows it, then the mortality comes down from 55 to 20%. So what basically happens is that a longer delay enables fibrosis of the underlying septum so that you can suture better and it stays better. So recurrence won't happen. So when to take up these patients for intervention, that's a very important question. There are many guidelines which indicate variable time frames wherein you can take the patient safely. 2013 ACC/HA guidelines indicated that you should always go for emergency surgery regardless of the hemodynamic status. 2017 European cardiology guidelines, they indicated that delayed elective repair gives better results. So current practice is that the timing of the surgery has to be individualized. It will depend on the hemodynamic condition of the patient, the expertise of the setup also. So important points here, as I have learned in my experience, are that tachycardia, intubation, I mean if the patient requires intubation, and decreasing urine output. These are three very important indicators that indicate that you should not delay further and go in for surgery as fast as possible. Now this is a very interesting timeline graph mentioned in the European Heart Journal 2014 paper by Jones et al. This indicates that by using various strategies, I will not elaborate too much, but people who are interested, they can really go into this diagram and understand that the red blocks are the mortality figures that are indicated against every approach that has been taken. For example, if surgery was done at 7 days, the mortality figure was 38%. If it was done within 3 days, the mortality was 47%. So this is a very interesting diagram that indicates that if you adopt a particular approach, what are the possible results subsequent to that. So if you don't do anything, almost 90% of the patients would die at the end of 1 month. So what is the role of PCI? Now this is a very interesting situation. Does it really have a role? So percutaneous intervention of the antiplatelets can be considered. It may be a salvage option in very gravely ill patients. However, the technique is still in an evolutionary phase. These are some of the devices available that have been used on some case report basis to close the VSDs in these situations. Of course, the results are quite, patients are in very extreme conditions, so the results may not be very good. The second possible complication would be papillary muscle rupture leading to acute mitral regurgitation. Recently, the incidence has declined in the reperfusion era, and the range is only about 0.05 to 0.2%. However, if it does happen, the mortality is very, very high. It may be between 10 to 40%. So, we all know that there is anterolateral and posteromedial papillary muscles, dual supply for one muscle and single supply for the other muscle. So, depending because of the fact that this posteromedial muscle has got dual supply, single supply, so the infarction rate and the injury rate to that is common. Our anterolateral papillary muscle is, since it is having dual supply, the rupture rate of that muscle is very infrequent. So you can see the two different papillary muscle heads with different blood supplies, and the rupture can be partial or complete. Complete rupture is rare. Means complete means the whole papillary muscle, let's say, necroses off and becomes flail. And if you see here, the angiogram shows the LED occlusion, and the papillary muscle you can see floating into the LV cavity. This is a 3D echocardiogram showing very much flail mitral valve leaflet because of the papillary muscle rupture. So it may, as I mentioned earlier, it can be partial or complete. And the hemodynamic disturbances can be severe because the LA is not dilated. It is an acute MR, and in different series we have seen different durations to rupture of the papillary muscle. Classically, it has been described as occurring within 1 to 14 days. In the shock registry, which is a more recent publication, the incidence of papillary muscle rupture has been shown to be maximum at the average duration of about 14 hours following myocardial infarction. So, what are the symptoms and signs? You will have significant tachycardia, tachypnea, and patients will have beat dyspnea, and the GFP will be raised. You will have a new pan systolic normal, and again, depending on the degree of fracture or injury, you will have different signs. The lungs will be flooded on X-ray. You will have elevated PA pressures, elevated wedge pressures, and you will have giant V waves or CV waves on the GVP. And of course, on angiography, you will have coronary artery disease. So to treat this condition, again you have to stabilize the patient for a short duration by using vasodilators, ACE inhibitors, diuretics, or vitamin. And invariably you have to use IVP support, and mechanical ventilation is usually required. You may have to consider supporting the hemodynamics by using either Impella or ECMO, and immediately you have to take this patient for definitive surgery. Now the question comes whether you should go for repair or replacement. It has been seen that replacement is a better option because it gives more, let's say, definitive result, predictable result compared to repair. You may spend 1 or 2 cardiologists do a repair, but it may not be working. So again, you may have to go in and do the replacement. So better to go in for straight away for replacement. you can use caudal sparing mitral valve replacement procedure so that the ventricular function is better preserved. And some small series have reported repair techniques, but they do again have mortality rates approaching 20%. And of course, concomitant CVD needs to be done to achieve optimal revascularization. If you see the results in shock trial registry, the hospital mortality rate was around 40% for patients in whom the concomitant mitral valve surgery was done with the CVG. Now, interesting here is that if with emergency MBR, CVG did not confer mortality benefit in early period. However, if you see the long-term outcome, CVG did definitely give long-term benefit because in terms of survival over a period of around 15 years. So, is there any role of interventional cardiology? If you have a very sick patient who you can absolutely, think that he is not a candidate for surgery, and in an expert setup, you may think of doing a transcatheter edge-to-edge repair. And in selected patients with pulmonary muscle rupture complicated by cardiogenic shock, it may be considered a therapeutic option in expert hands. So these are some of the devices that the mitral clip and other newer devices which can be considered to salvage a very, very sick patient in the catheter. So coming to the last one, the pre-wall rupture. It is seen in about 10 to 30% cases in some of the autopsy studies that have been published. The incidence in clinical series is 2 to 5%, and it accounts for about 15 to 20% of early deaths. It is much more common in elderly women, and it occurs, very interestingly, it occurs mostly with the first acute MI, not with the second or third one. It occurs with the first acute MI in the patient. So it occurs between 1 to 7 days. The peak incidence is between day 5 to 7. And if you see the statistics, within 24 hours the incidence is 3%, by day 7 it's 80%. So most commonly the LV free wall is the one that gives way. It can be seen in RV free wall also, and these are the coronary arteries that are usually illuminated. LAD around 40%, NCS also 40%, RCA 20%. These are the three different types of free wall rupture. Type 1 occurs during the first 24 hours, Type 2 occurs within 1 to 3 days, and Type 3 occurs late. Some of the morphological features are also different, so that may have a bearing on the surgical management of these three types. So how they present, the patient presents with acute chest pain, suddenly there is progressive hypotension and there is electromechanical dissociation and patient will collapse. I am sure all the cardiac surgeons have in their experience encountered this problem, and the patients may have come with acute coronary syndrome and then suddenly collapsed after variable days of MI. So the echocardiography is diagnostic. You will get a large pericardial effusion and signs of tamponade, and you will get echodense masses as the effusion part in the pericardium. So there is also early diastolic, very large amount of early diastolic collapse of the RA and RV. So essentially the repair, there are in a way two techniques of repair. You can do a linear closure where you place horizontal mattress sutures with the placement of a Teflon felt. You can reinforce it with additional pericardium, and this kind of linear repair is possible in small tears. And sometimes you may have geometrical distortion of the ventricle, but that usually is acceptable, and you can manage some degree of reduction in ejection fraction because of that. Then you can also do an infarctectomy wherein you excise some part of the infarcted ventricle, and this approach is reserved for larger ruptures, and then you subsequently repair it with the proper patching procedure. And you can also have a patch cover wherein you don't really suture the actual defect. You place a glue on the epicardium and then place a large patch and then suture it in the periphery. So these are several techniques that are available, and it is very important to have a high degree of suspicion. And opening means while doing sternotomy you have to be very careful. The whole team has to be very alert, because as soon as you open the sternum and the pericardium in these patients, the patient will have significant, it's complete collapse. So you have to be very much ready to go on bypass immediately. So coming to the final concluding slides, just to summarize the management of these three important mechanical complications, multidisciplinary team is very important because these are complex problems and it obviously requires collaborative efforts. So this multidisciplinary team is required for accurate diagnosis, deciding the best course and timing of management, and then deciding the modality of hemodynamic assist that needs to be employed. And of course family counseling is very important because these are all very sick patients who can fare either way. They can go towards improvement or they may not be able to survive. So clinical treatment should be instituted very early in all cases of mechanical complications. It should be carried out in intensive special coronary care units. Appropriate use of inotropes and vasodilators is mandatory to ensure hemodynamic stabilization. Use of IVP is mandatory in all these mechanical complications. It helps to stabilize the patients and it prepares him for surgery, and definitely the patient behavior is much better with the use of IVP. So to conclude, these are highly unstable patients with treacherous tissues, and surgical results are best in experienced hands, and constant vigilance is needed in the early post-operative period for adverse event that may occur. Thank you.